honestly, you have to keep in mind that all the nice anatomical dissections and the structures that we saw in the previous lectures are very hard to encounter during surgery, as you all know. So I think DTI-Tractography has had a revival. So here you see the 2014 cover of National Geographic. And this was actually the main hype of the DTI-Tractography in surgery. So I just want to mention some basics first so that we know what we are talking about when we talk about DTI. So it's all about diffusion. Diffusion DTI-Tractography was originated actually already from Einstein in the last century. But what it's all about, it's movement of molecules. And actually, it's the movement of molecules in the liquid, the Brownian motion. And they move from low concentration, from high concentration to areas of low concentration. And if we talk about DTI, it's always about anisotropy. Yeah. And just to introduce this word, what it does mean is if we have isotropic diffusion, then as you can see in the left picture, the molecules can move in all directions at the same speed. So whereas if you have anisotropic restricted diffusion, as in axons, as in fibers, then we have a certain direction of the movement. So as you can see that here. So our water molecules, and that's what all DTI is about, they move parallel to the axons unlimited. Whereas in fibers and in brain, that is mostly composed of fibers, as you know, the movement is restricted parallel to the fiber axis. So going even deeper, what about the diffuse intense imaging now? For each voxel in the DTI image, we assess the diffusion in the different directions. And now what we do is we take at least 30 directions to get a good signal to noise ratio. And the radiologists call this the gradient images. Yeah. So in every voxel, we have 3 vectors. They're called eigenvectors, in fact, actually a German word. And lambda 1 is the longest, the typically longest eigenvector, which is the direction of the maximum diffusion. And it's the one that we want to take care of when we calculate fibers. Yeah. So if we have isotropic diffusion, then we have this ball-shaped type of vectors. So there is no maximum vector. So there is no net direction, in fact. If we have maximum anisotropic diffusion, like in fibers, we will have this cigar-shaped eigenvector, which has one main direction. And then for us, doing DTI-Tractography and trying to recalculate the fibers in the living brain, we post-process this data with a mathematical algorithm. So what we do is we try to find the most likely fiber direction from one region of interest, as you all know. So we set the box somewhere, and from there, we try to calculate fiber directions. We usually use deterministic fiber tractography, which is called the streamline algorithm. That's what it looks like. So you see for each voxel, the primary eigenvector, yeah? And every eigenvector is connected to form a fiber. And remember, we can change our angle that the fiber tracking algorithm uses between voxels. And of course, we can change our anisotropy, which means that we can change the number of fibers that we have, in fact. Probabilistic algorithms would be even more intelligent because they can calculate even crossing fibers. So the probable direction of the fiber, but of course they take a lot more calculation power, and they're still not really into the clinical field. So here again, the basics. Let's go to the electron microscopic structure of an axon. So here you see the microtubules, yeah, at the nanometer scale. If you look here, you see the axon, here the microtubules inside, and we are talking about water molecules. Don't forget that. Yeah, so it's that small size. So here you have the axons with the glia or Schwann cells. Then here in this picture, you will find the eigenvectors. Here you have a gradient picture, so that's one direction. And then here you have a superimposition of all gradient pictures. And as you heard before, we have all the different fiber systems, association, and for example, the association fiber systems here are typically calculated in green. Yeah, so the intrahemispheric fibers, like here the cingulum, for example, superior longitudinal fasciculus. So you see all these fiber systems color coded in different colors. Red is left, right, and blue is up, down direction. Okay, so now we can work. Here you see a very nice tractography of the corticospinal tract. This is from the Medtronic StealthWiz software, and you see the regions of interest that we set in the pre-central gyrus. And here you set the regions in the midbrain, so in the crus cerebri. So what about the application of this DTI tractography? I think we have to have some critical concept about it. So we can use it, of course, for any pathology that's in the vicinity of, we call it eloquent fiber tracts. Of course, you can use it for every fiber tract. And we use it for approach planning, especially if we have an fMRI, and the fMRI shows us the region of interest. And of course, intraoperatively, it can help us to localize those tracts. But please be careful. This is related to a preoperative imaging, and it's not gold standard. Gold standard, we still believe, is electrophysiology. Yeah, so cortical, subcortical stimulation can, of course, directly show us where are the fiber tracts. And DTI tractography is a navigation image that's related to a preoperative image and prone to brain shift. We use it in our fluorescence guidance cases, that it prevents us to remove too much of the fluorescence. Of course, you're always prone to remove all of the fluorescence of a glioma, but of course, in the peripheral areas, there may be still some functioning tract, so it can help us there. And combined with subcortical stimulation, it helps, we think, to maximize resection and minimize damage. So I think it's quite a good tool. But beware, it's difficult to find the appropriate regions of interest, so you have to have some experience. Beware, there's a distortion of the DTI pictures that is larger than the anatomic images. Yeah, so you need some post-processing to adapt this distortion. The accuracy is low. Accuracy is about 2 millimeter voxel size, maybe a bit less. Yeah, don't forget that. So what the fiber you see is not an axon. It's a large bundle already. Yeah. And of course, never forget the accuracy of your navigation, depending on not the image modality, then the distortion, and then the registration. Yeah, so all this adds up. And what is important in areas where we have low anisotropy, yeah, so where the membranes have been destroyed, it has limited value. So here I have an example which I like. So this is a metastasis, and you see there's the edema around the metastasis on T2, and the edema means that, of course, the blood-brain barrier and in fact the membranes have been disrupted, and that's why you see this area of low anisotropy. Yeah, so where fiber tracking may not work as well. But on the other hand, of course, it can give you the chance to picture, to visualize very nicely anatomy, especially if you compare it, if you combine it with brain surface visualization. So here you see, actually, that's a cavernoma in posterior left T1. Yeah, and of course, we wanted to know before this, we did awake surgery, where is our arcuate fascicle? And this was the first time we tried to superimpose arcuate fascicle underneath a surface, a translucent brain surface, and see how nice you can see actually the piercing of the fibers into Broca's area. I mean, this is really like an anatomic preparation, isn't it? Piercing in Broca's area here, even some fibers to Geschwind's area, and here fibers to Wernicke's area. Yeah, and you see very nicely, of course, how arcuate fascicle rounds with the ventricular system. So I have prepared some cases, and please be in mind, these should be some very standard cases that help you to do what you can use DTI tractography in your daily praxis. Let's see how many of them we can do. So this is a 20-year-old female with a right precentral F2 low-grade glioma. She's a medical student and she's left-handed. So actually we were a bit scared. She may really be right-sided dominant. So here you see actually the pathology on FLAIR and T2. And it's probably a low-grade glioma. As you see, there's no contrast enhancement. And here are some additional images, but we wouldn't expect any amazing choline NAA this ratio or any perfusion enhancement. So, but this was interesting because most of our people, where we showed this picture, got the anatomical position of this glioma wrong. So we had the idea, let's try to find out what is better, 2D or 3D. So we did a little study at that time, comparing 20 cases, in 2D and 3D in 10 of our residents. And we gave them first the 2D pictures. And this relates, of course, to our first talk from Matthias. So I just wanted to show you how hard it is for everybody to understand the surface anatomy. So in 2D, they did an error of 20%. So every fifth answer was wrong. And a couple of months later, we gave them the same images in 3D, the same case in 3D, and they did only 7% wrong. And look at the time they needed. For the 2D, it took them nearly an hour. And for the 3D, sorry, it took them only 8 minutes. So, sorry. So this was statistically significant. So at that time, we did a brain surface study and we developed, I think I have to get some water, just a second, sorry. So perfect. So this is why in conferences you always have the water bottle on the side. Sorry for that. I'm here again. Can you still hear me?
Yes, yes, perfect.
Now you turn off your microphone.
Now you can hear me.
Yeah.
Yeah, perfect. Sorry for that. So we developed a little algorithm that helps you to subtract your DTI image from a T1 image. And with a click of a button, you get this very, very nice brain surface. And we think this is very, very useful in most of the, especially intrinsic tumor cases. So then we thought, what about the vasculature? And we realized that in a normal T1 MRI, you can see vasculature down to a cutoff of 0.7 millimeters. And of course, you can use these pictures very, very nicely to plan your approach and to coordinate your brain surface with the real anatomy. So look at this picture now. It's a 3D anatomy picture of your brain surface. Here's the tumor. The tumor is from T2. And here is the precentral gyrus. And the precentral gyrus is what we usually derive from tractography, from the corticospinal tract. Because we believe that the few spots of fMRI are not enough, in fact, to see the whole, to find out the position of the precentral gyrus, especially if it's distorted with tumors. So we use, for example, corticospinal tract tractography to calculate our position. So then here in coronal, you can see very nicely, here is the corticospinal tract divided by that tumor. Here you see the arcuate fascicle. So we did that awake. And look here, the intraoperative picture. That's a micro picture through the microscope. She was awake, so that's why here is our electrode for stimulation. And let's be honest, it's quite difficult to find out where the tumor would be here. Yeah, but if you have this surface image with your precentral gyrus from corticospinal tract and your T2 tumor, it's very easy. And especially if you use the vessels, you see here the Y-shaped vessel, then you immediately know this will be the tumor to resect. And this is what we did. You can see that here. And actually, she did very well. We did the stimulation, of course. And here you see the post-op image and you see the post-op 3D image. The tumor is gone. So again, this is the first reason why we use DTI-Tractography to calculate where are our functional regions, where's precentral gyrus, where's Broca area, because that's where the fibers pierce. Coming to the next case, so this is what we call a trigonal glioma. So here we would be interested, we thought, in the ventral stream, and you see that's a very, very high perfusion, so we probably have a malignant glioma, that's what we expect. And you see here our ventral stream, yeah? Our IFOP is here, our inferior longitudinal fascicle is here, in the middle will be our optic radiation, as we heard from Pablo before, and here is the arcuate fascicle on the left side. And you see very nicely what curvature shape it has and how close it comes to that tumor. Yeah. So this is what we used for resection in this case, and actually we also planned our approach with this case. I think this is also a very good indication for fiber tracking. And you see here, that's the post-operative image. Okay, so let's go on. What I like to use personally, I like to know always where I am. And usually when you use navigation, you use optic navigation. And again, you have to take the pointer, you have to maybe move the position of your microscope, your assistant has to move away. So it's very cumbersome. So that's why I usually use a navigated suction that is self-made, very easy, a standard suction, and you just put this, what is called electromagnetic stylet inside. You don't even have to pin the patient in a clamp. Many craniotomies I do without putting the patient in a clamp because it's just not necessary for this type of navigation. This is just to show you how it works. So here we have a left P2 glioma, obviously, again, a high-grade glioma. And you see our tractography. So what I also can recommend you is always use the same coloration. So here you see the corticospinal tract, yeah, medial to it. Here you see the arcuate fascicle, and here you see the Broca voxel. The Broca voxel coming from fMRI. So all is very closely related to the medial aspect of the tumor. And this is the video, and I hope you can see it quite smooth. But again, remember, we always had the same color code. So we immediately know that yellow is arcuate and green is corticospinal in every surgery. Yeah. And we have this color code for all different fiber tracts. So here's the electrophysiology. Here's the cortical stimulation. What I would like to let you know is here's our tract suction. So while we resect this tumor, we always know where we are and how close we are to the tracts. And here is the 5-ALA fluorescence. And of course, we are tempted to remove all the fluorescence, but there will be fluorescence even within those fibers. Yeah. So that's why we better take care and stop our resection early enough before we damage those fiber tracts. And this is, I think, a very reliable method using a direct navigation of your suction. Another one, here you see a left low-grade glioma, F1, F2, as you can see on the coronal picture. Again, the advanced imaging, there's no PET hotspot, maybe a small PET hotspot here in the middle, as you can see. We always do our brain surface. As I told you, we always have our corticospinal tract in green here. Yeah. So, and this is again how we work. We always put our PET inside, we put our corticospinal tract inside, and here's our tract suction. And this is a special type of suction. You see the plastic covering outside. So this can not only irrigate, but it can also stimulate because it covers the suction metal. and at the tip, the suction metal is free, and we use it as a continuous stimulation. Yeah. So there's a small video, but I think for the sake of time, I will jump over it. This is just to show you how the suction works. So this is a plastic covering from the anesthetist tube, yeah, leaving the metal tip off so that you can stimulate by this cable the suction continuously. And also here you have your navigation, yeah, and here you have your water jet dissection. So that's very, very useful. And look at this case. That's white light, that's ALA light, and it was mostly low-grade glioma, but there were foci of high-grade glioma, so GBM. Yeah, so that's the post-op picture. So let me check what I would like to show you more before we end. So here's a nice case of a young patient, 25-year-old sports student, and he was kicked at the soccer game into his into his left leg, and he fell down and couldn't get up anymore. But it wasn't the kick in his leg, it was the bleeding in a cavernoma, yeah, that caused his plegia of the left leg. So he recovered after some weeks slowly, and we found out that he had this cavernoma in his left lower extremity area. So here we did some 3D planning, and we convinced him that now is the right time to remove this cavernoma, because of course now you have the bleed and you have the space to remove it. Again, in green, you see corticospinal tract here, very, very close to it. And here's the image. Here see our suction tip is free. We're continuously stimulating because we want to know where is precentral gyrus. So then we do a transsulcal approach that we had planned before in precentral sulcus. And we have done a trajectory, of course, through the white matter into the cavity of the cavernoma. And in green, you see again our corticospinal tract. So we are very close. So now we're going a bit faster through the cortex, through the white matter, just for the sake of time. And following all this trajectory, we're kind of blind at the moment now. The only thing we know is the navigation and the stimulation of the suction tip. Yeah, and suddenly we enter this cavernoma cavity. You see the cholesterol crystals inside. Yeah, and you see how small this approach is. We open the cyst and suddenly we stimulate lower extremity at 5 milliamps. So we think we are still 5 millimeters away. Yeah, because we know 1 milliamp corresponds to 1 millimeter, but suddenly we stimulated 1.5 milliamps. So that's very dangerous. 1.5 milliamps is exactly at the tract. Yeah, we know that. So then we carefully dissect the cavernoma and leave the DVA alone. There's quite a big vein inside. Yeah, and see, we always get a continuous update on our screen from our electrophysiologist. So here's the lower extremity. Yeah, and again, being very, very reluctant because of that 1.5 milliamp stimulation, we still are able to remove the cavernoma, preserving that large vein, as you can see here. Yeah. Okay. I think that was good. So you see the post-operative image, and actually he did some improvement over the next weeks and could continue his sports studies. I don't know if he still plays soccer like a Brazilian now. So just my last example should show you that you can also use tractography for biopsies. And you see here, that's a very deep lesion, contrast enhancing lesion in the posterior limb of the internal capsule. So usually we would approach this with a needle from the front. Yeah, you see that here. That would be our regular trajectory from the front. If you use fiber tracking, however, and have a look at your corticospinal tract, you would immediately pierce through the corticospinal tract if you use this frontal approach. And of course, you can say you separate the fibers with your needle. But in fact, if you see this once, you wouldn't do it. So you better plan a different approach and come from T1 on the side. Also, T1 on the side is not that easy because of course you want to go transgyral, you want to stay below the insula, circular sulcus of the insula, and you want to stay over the temporal horn. So that's not a very easy approach, but we did it. You can see that here. So that's the live surgical video, and I think we made it. We didn't aspirate any CSF, but only tumor. So here's the tumor. It's the 5-ala light as we always do it, and it was a GBM. It could have been a lymphoma, we thought, but it was a GBM, in fact. Don't want to go into detail of this. Okay, so for the sake of time, just some further applications where we use DTI-Tractography. If we do a transcallosal approach, we always try to avoid fibers that cross the precentral gyri over the corpus callosum, so we stay in front. We all know that, but now we can even track those fibers. When we do limbic gliomas, we trace typically the cingulum, and we try to preserve those fibers as much as possible. That was quite a rare one, an interforniceal approach with it's actually a meningioma in the third ventricle, interforniceal approach where we had a fiber tracking. And of course, we usually use it for brainstem cavernoma. That's already the new software of Medtronic, creating nicer fibers. And you see, you can really check your safest entry zone using fibers and of course, direct simulation. We have also published some image fusion recipes. So you see, this is our recipe for low-grade glioma, and it's always incorporating brain surface visualization. Yeah, that's what it looks like at surgery. And you see the suction, and I can really recommend that the suction is very valuable if you can always see where you are. And with this, I thank you again very much for your invitation. And I hope you can take some of this lecture to the OR. Thanks.
Thank you. Thank you, Stefan. Thank you so much.
Welcome.
It was beautiful. Thank you.
Thank you very much. Let me ask you, before start, a question from the audience. Wonderful presentation, Stefan. Thank you very, very much.
Thank you.
How you fix the navigator to the suction?
I don't. Do you know electromagnetic navigation? Do you?
Yeah.
Yeah. So it has this long stylet. Yeah.
Yeah.
And I take my normal suction, single-use suction, and it has this rubber tube in the back. I
put that. Okay.
I make a hole, yeah, with my scalpel, and then I put it through the suction, yeah, to the very tip. Yeah.
Okay.
I can send you some instructions how to do it. It's so nice.
Is the stealth the stealth station? Yes.
Yeah.
The 7 or 8 you have.
But it works on 7, on 8. It works even on BrainLab has one now, but we use it on S7 and S8. Yeah, and it's perfect. You know, no clamping. You always know where you are. No line of sight visual issue. It's super.
Dr. Stefan,
Great, thank you.
We have some questions for you from the audience and for all the other panelists as well. And I'll start with this one, just has arrived. Dr. Kamabu said, thank you for your wonderful presentations. What are the risks of irradiation of D2 compared to with D3?
T2 compared to 3, irradiation.
Irradiation from D2 to D3. That's what he said. I don't know exactly what he meant.
Is he talking about middle temporal gyrus and inferior temporal gyrus, like
no,
T2?
D2, DTI, I don't know. Well, let's go to the other.
I don't know.
Okay. Dr. Stefan, I just want to comment something. Hi, how are you?
Hello.
Hi, how are you? I think it's a nice idea to combine different instruments, like you are combining the suction tube with the neuronavigation. I tried aspiration tube, there is also a stimulator. Now I'm just thinking that you can put the stylet inside, maybe inside the suction as well.
Eduardo, this is what I tried to show. This is what I showed. We always use the suction as a stimulator plus navigation.
Then you have 3 instruments in one hand. It's amazing.
Yes, and you can just work. You know, you can just work. You never have to change any instrument in your left hand.
No.
Yeah.
Let's make a question for Stefan. You still use the neurophysiologist or not?
Yes, all the time. Yeah. When we think we get
the people here in Brazil is very concerned about this.
Why?
Because they are not cheap, Professor Borba.
Yeah, but you know, I usually we have many stations, electrophysiology stations, and what we do is we put the electrodes on the patient, yeah, and then we tell the electrophysiologist, so please set my threshold to 10 milliamps, so that's 1 centimeter away, yeah, and when I approach it with my suction, it beeps, so I know I'm getting there. I don't need the electrophysiologist sitting there, yeah. It just gives me a beep and I know, okay, now I'm getting close to the corticospinal tract. And honestly, it had helped a lot of times.
Dr. Stefan, there is a question here from Dr. Rena. He asks you, how can we get the 3D brain image? What kind of station you use? It's what equipment is GE or Siemens or? No.
This is all from Medtronic StealthViz,
right?
The DTI software.
Okay.
And S7 or S8. So, but it's StealthViz, this tractography tool.
All right. Great.
Yeah.
Thank you.
Felipe.
Gabriel Vargas.
Last question, Dr. Vargas. Last question. You can go ahead. Okay.
All right.
Dr. Vargas,
hi, Gabriel. Hi, Gabriel.
Hi, Stefan. How are you? Nice to see you here. And congratulations for all the speakers and everybody. And we need to combine the knowledge of the anatomy with physiology, as all of you said. It's easy to find maybe cortical tracts and things. How about optic tract, Stefan? It's easy to find it by stimulation. How do you find the optic tracts on a stimulation? Because it's easy motor areas, verbal areas, but that optic tract, do you have some experience trying to really reach and find that optic tract in surgery?
So, Gabriel, this is a very good question. Yeah. And although we always see these very, very nice fiber preparations on anatomy, and even those are very, very difficult, as I'm sure that Paolo can confirm, it's even more difficult to find those fibers with tractography. I recently, actually 2 days ago, I tested the new Medtronic software with a probabilistic algorithm, so with a very sophisticated algorithm that can find angles and crossing fibers, and I was still not able to do a perfect Myers loop. So for tractography, it's very difficult. So what you usually track is the ventral stream. Yeah, so all the IFOF, the ILF, and the optic radiation. This big bundle, this sagittal stratum, that's what you usually trace and see. And then relating to direct stimulation, we don't do that. I know there are people who do it, who do awake surgery. I think Pablo Gonzalez has shown a case, direct stimulation, having the patient awake and looking at images, but I have no experience with it. Our electrophysiologists don't do it. Yeah, it's tricky and it's not standard.
Yes.
Okay. I apologize for the participant, the panelists, but you have to continue because you have the lecture of Dr. Dufault at noon. Okay. And the idea after the presentation, maybe you can continue to talk here, or you move do full lecture. Thank you, Professor Stefan. Thank you, Paulo. Let's go ahead. Who's the next one? Is Dr.
Álvaro
Wayne?
Okay, thank you, everybody.